Estrogen reduces the risk of cardiovascular events. It may even reduce the incidence of Alzheimer's disease.
Welcome to Wellness, your ultimate guide to unlocking your full human potential through biohacking. I'm your host, Ashley Daly. I'm a certified sports nutrition coach, and I have a degree in kinesiology, and I'm a former personal trainer and Pilates instructor. If you're listening on YouTube, hit subscribe, as it helps listeners just like you find this hidden health information faster. Did you know red wine doesn't actually stain your teeth? It's the artificial dyes they add to the wine. But that's not the case with Dry Farm Wines. This is an exclusive wine club which brings you natural, organic wine sourced from farms across Europe who practice regenerative farming. All wines, like this one, are completely sugar-free and fully fermented with less than 1 gram of sugar per liter. You can enjoy your wine without any artificial dyes, preservatives, or sugar. Because you're a loyal listener of Welcome to Wellness, you'll get an extra bottle for just 1 penny on your first order. That's just 1 penny for a beautiful, natural, organic wine. Visit dryfarmwines.com/Ashley Daly. Today's guest is Dr. David Lanz, the medical director of Integrated Rheumatology of Westchester in New Rochelle, New York. He's a board-certified osteopath physician with over 35 years of experience, and he specializes in rheumatology, immunology, and integrative medicine, including bioidentical hormone replacement therapy, regenerative medicine, and longevity-focused care. Dr. Lanz emphasizes root cause analysis and prevention over symptom management, blending traditional training with anti-aging and metabolic medicine. He trained at Des Moines University, SUNY Downstate, Tufts, and Hospital for Special Surgery Rheumatology. Currently, he serves as Chief Rheumatology at NYP Lawrence Hospital and Assistant Clinical Professor at NY Medical College. He's a Fellow of the American College of Physicians and is triple board certified in internal medicine, allergy, immunology, and rheumatology. Dr. Lanz integrates traditional training with proactive wellness, metabolic, and preventive medicine. As we age, he says, we wish not only to prevent disease, but also to live active, vibrant lives. Dr. Lanz, welcome to the show.
Thank you very much, Ashley. It is a pleasure to be here.
I'm so excited to have you here because you were referred to me by one of my favorite physicians in the bioidentical hormone replacement therapy space, Dr. Angela DeRosa. So for listeners hearing about you for the first time, can you please give us a brief overview of your background?
Sure. And by the way, I think Dr. DeRosa is wonderful too. We're both fans of hers. I practice in a solo practice in New Rochelle, New York, and my background is interesting. I'm an osteopathic physician. Osteopathic physicians in general are oriented in their approach to healthcare in a little bit more of a holistic way and are more open to, I would say, unconventional ideas. And that was always sort of my orientation when I first got out of medical school, which was a long time ago, a very long time ago. But following my regular medical training, I trained in internal medicine and in rheumatology, as well as allergy and immunology. So I did a lot of time in postgraduate training. And in those days, I was really practicing conventional medicine. And for a while, I was practicing academic medicine, teaching at Albert Einstein College of Medicine. And then I went off into my individual solo practice. And as the years went on, I began to question a lot of the sort of conventional ways that we approached patients. And it kind of concerned me that we were always just treating diseases and then treating symptoms of diseases. And I became more and more interested in understanding how to help people prevent their disease, how to help them be healthy, how to understand why diseases develop in the first place. And that sort of moved me into the functional medicine space and trying to understand more about that. And as a consequence of that, I went on to some training with the American Academy of Anti-Aging and Regenerative Medicine. That really oriented me to a lot of the functional medicine approach. And then I was able to take the two disciplines and bring them together into an integrative medicine. So today, my practice is what I consider integrative medicine, and I practice both a mixture of conventional and, I would say, functional medicine. Now, with respect to hormones, it's a slightly different story. That was kind of a parallel story, but the actual story of hormones is about 15 years ago. My wife was going through terrible perimenopausal symptoms, and she was really struggling. So we sent her to the gynecologist, of course, which is usually the first step for most women who go through this. And she came home with a prescription for Prozac, which I immediately told her to throw away. I said, that's not what the problem is. The problem is we're having a hormone issue. And to make a long story short, she went to several gynecologists before one of them called me up and said, David, your wife is having estrogen deficiency and going through menopause. And I said, I know, she's really struggling. She said she needs bioidentical hormones. And I said to her, what is that? And she told me a little bit about it. And I said, well, go ahead and treat her. And she said, well, I don't know how to do it. So that led me on this journey in which I did a deep dive and really learned as much as I could about menopause, hormone therapy for women. At that time, back then, 15 or 16 years ago, everybody was afraid to use hormones because of concerns about the risk for breast cancer. And most people weren't doing it at all. And by really doing a deep dive and studying it in depth, I learned that, well, that was not the case at all. And that it was a terrible tragedy that millions of women who were going through menopause were being denied the proper treatment. And either they were suffering or they would come home with prescriptions for antidepressants. So I began practicing hormone replacement therapy for women and for men too, actually. And that practice just grew and grew. And this was going on sort of alongside my interest in functional medicine and my journey in that direction. So today, my practice is, a combination of hormone replacement therapy for women. I also practice integrative medicine, longevity medicine, healthcare optimization, and an approach to certain diseases which tries to understand the causes and focus on lifestyle and nutritional approaches.
Oh my goodness. Thank you for sharing all of that. There are so many layers that I want to dive into. I didn't know that you went to or belonged to the American Association of Anti-Aging and Regenerative Medicine. I feel like that institution and the physicians who go to it, in my opinion, are cream of the crop. Top physicians who are looking for something more than what you had mentioned, the traditional way of practicing medicine. David, I have the exact same story of a girlfriend who was suffering with perimenopausal symptoms. I actually picked out a gynecologist for her in her area that I thought was good, and she left with a prescription for antidepressants as well. I think where I really want to start is, what are these hormone fluctuations that are a part of perimenopause and menopause?
Well, the average age for menopause for a woman is around the age of 51. And the problem is that we define menopause as the circumstance in which a woman hasn't had a period for a year. And that's fine in terms of defining menopause in a conventional way. But the reality is the majority of women who are going through hormonal changes begin to experience those changes long before that. And many women in their 40s will begin to experience some hormone fluctuations which cause symptoms, but they still may be having periods. Typically, they start to have irregularity. Their periods may come in 60 days or 40 days, or they start noticing changes. Many women will say, I was always like clockwork, and around the age of 41 or 42, I started to experience these difficulties. And in conjunction with changes in their cycle, a lot of women will begin to experience a constellation of problems. They may be sleep difficulty. They may be irritability or anxiety. It can be joint pains. It can be the classic hot flashes and night sweats. It can be changes in the skin and the hair. And every woman is different. So some women, these changes will occur very abruptly and suddenly they'll come on. In other women, they won't experience any of them. And some will gradually develop. So it really requires an awareness of some of the symptoms that can occur early on. And the first thing that typically happens to a woman who may be in her mid-40s, let's say, is that she starts to have a deficiency of progesterone. And that usually is the most common first thing to happen, that the estrogens are still okay, but she begins to lose progesterone, particularly in the luteal phase or after the ovulation phase, second part of the cycle. And what often will happen is that will lead to things like difficulty sleeping, a lot of PMS-y type symptoms before the period, a lot of irritability. It can be easily addressed if it's recognized. What I'll often do is if I see a woman who's in that phase of her life, I will often just give her a little supplemental progesterone, particularly in the latter half of the cycle. And I'll say, right now you don't need estrogen, but you need some progesterone, and that often helps tremendously. We also always use bioidentical hormones. And I just want to stress that because some people are confused about what we actually mean by bioidentical hormones. Traditionally, hormone replacement therapy for women in the past, at least before 2000, the common use was Premarin and Provera. That was the standard treatment. The oral progestin, which is Provera, which is a synthetic progesterone and not actual progesterone, and Premarin, which is a synthetic estrogen derived from mares, from horses, which contains a large number of different estrogens, and only a small portion of which are actual human estrogens. So when we want to replace hormones in a woman, we want to use bioidentical hormones, the actual hormone that the woman is missing. No longer producing enough progesterone, we want to give you progesterone, not a drug that acts like progesterone. And if you need estrogen, we want to give you estradiol or estriol, which are the important estrogens for a woman, not a synthetic version. And that's really very important. And most people today, I think, are focusing on bioidentical approaches to hormones.
You touched on a lot of things here that I want to unpack. So you said you would give a woman progesterone as maybe one of the first hormones when she starts to experience these symptoms. My question is, when she has an irregular cycle, say her period comes every 40 to 50 days, where in those days do you then take progesterone?
It can be a challenge. In fact, from the point of view of the treating physician, it is much easier to treat a truly menopausal woman whose ovaries are not making any hormone, so you're just giving her what she requires, in contrast to a woman who's going through perimenopause, which can last 10 years for some women, because there's so much variability in her production of hormone from the ovaries. It seems that the ovaries are getting irritable, and some days they'll go through a period where they'll produce plenty of hormone, and then some days they won't produce any, and that makes it very challenging. So what I usually tell women is you want to count from the first day of the period. The first day of the period is day one. It's best to try to assume a 28-day cycle. So if right around day 15, I say, that's time to start your progesterone. So take the progesterone from, let's say, days 15 to 25, and then you can stop it, and usually a period will come. Sometimes it doesn't. And if it doesn't come because the cycle is so disrupted, then I'll say go back onto the progesterone, and when you do start to get some letdown, stop it and start counting from day one again. And I will just say sometimes, in some cases, I will give her a lower dose in the first 14 days, and then the second 2 weeks of the cycle, I'll have the dose slightly increased.
Since you said dose, do you have a reference range of the kind of dosing that you'll give someone?
Yes. Well, just to talk about progesterone for just a moment, I want to stress that any woman who's on hormone replacement therapy and who has an intact uterus must be on progesterone. And we can get into that a little bit later. But it's very important that women don't forget that, because for many women, especially once menopause has taken place, the big difference is going on estrogen. So a lot of women, I have to remind them, how you taking your progesterone, because the estrogen really solves many of the symptom-related problems that emerge. So the dosing depends on where she is, her age, and how much progesterone deficiency I anticipate she has. So for example, if she needs complete replacement levels and she's menopausal or has undetectable progesterone in the blood, I'm more inclined to give her anywhere from 1 to 300 milligrams of oral progesterone. I would say most commonly 150 milligrams. That's orally. If she's choosing to take it by a cream, then I will use a lower dose, because when we take it in the oral form, it goes through the liver and a lot of it is metabolized. So the dose is actually higher when it's taken orally than when taken transdermally or on the skin. I typically will recommend doing it orally because progesterone is calming for a woman. And when the progesterone gets into the crosses the blood-brain barrier and gets into the brain, it binds to the GABA receptors, which helps to reduce any type of excitation and anxiety, and it's very helpful for sleep. And things like anxiety and irritability and agitation are common during this phase of a woman's life, and it really helps to give the progesterone, which is one reason why I typically will give progesterone even to the woman who's had a hysterectomy for another reason. While she doesn't absolutely need it to protect the uterus, I think it still balances her hormone levels. So I typically will recommend it for all women. And Some women prefer not to take it orally, but I find that that's most helpful for sleep and relaxation. Now, when a woman is younger and she's...
Can you tell me why it's important to take it in oral form for sleep and relaxation over the topical cream form?
Yes, because when we take progesterone orally, or for that matter, when we take any medicine orally, or drug or hormone, we absorb it through our gastrointestinal system, it goes into our liver, and the liver may metabolize it prior to distributing it throughout the body. And in the case of progesterone, it is extensively metabolized by the liver. And one of the main metabolites that comes out of the liver is a metabolite called allopregnenolone. And allopregnenolone readily crosses the blood-brain barrier, and it's very effective as a calming agent. It's almost like a natural hormonal Valium in a way. So it's very useful when you take it orally. If you take it by cream form, since you don't have that liver pass effect, you don't have as much of the progesterone crossing into the blood-brain barrier, and some women won't get as much of the benefit when they take it in a cream form. A woman is in her 40s and she's going through perimenopause. The dose of progesterone is typically lower because she's probably making some already. We just want to supplement it so she doesn't become deficient. So I tend to use about half that dose. But it's a very, very safe hormone, so you don't have to worry as much about giving too much. If you give a woman too much for her biggest complaint will be that she's tired, because it can make you feel, because it can be sedating for some women. So sometimes you have to be careful that if the dose is too high, she'll feel drowsy during the day. And I've had that situation. Occasionally, progesterone can cause people to have things like breast tenderness or bloating, which will sometimes occur. And you have to, always monitor for that. But I would say that the majority of women tolerate this hormone extremely well.
Now, I want to go back to what you said about taking progesterone if you've been giving estrogen, because my mom was recently given an estrogen prescription. And I said, and progesterone? She said no. And I said, that's malpractice. You're not allowed to take estrogen without progesterone. So even though I'm not a doctor, I still like to give my family medical advice. So can you tell us, David, why you need progesterone with estrogen?
So if a woman takes what we call unopposed estrogen without progesterone, the estrogen will stimulate the endometrium, or the inner lining of the uterus, and that can lead to a condition called endometrial hyperplasia. It can lead to spotting and bleeding, but more importantly, it can lead to endometrial carcinoma, cancer of the inner lining of the uterus. And this is absolutely protected against by using progesterone. So progesterone absolutely protects a woman from that risk. And if she's taking the estrogen without it, there's a much more significant risk of developing endometrial cancer. And in fact, that's really the only really significant cancer risk that people need to worry about when they're on hormone replacement therapy. Everybody's concerned about estrogen and breast cancer, and we can get into that a little bit. But I'm strongly of the opinion that there's really no good evidence that estrogen supplementation causes breast cancer. There's very good evidence that it causes endometrial cancer if you're not taking progesterone. So get your mom on the progesterone.
Okay. Yes, sir. I'll make sure she listens to this. She's usually pretty good about listening to almost every episode. Okay. So earlier you had mentioned the two types of estrogen that you would prescribe someone.
When we talk about the sex hormones, we're talking about estrogen, testosterone, and progesterone, right? And it's a little bit confusing because progesterone is a compound. It's a hormone, progesterone. And testosterone is a compound. It's a hormone. But estrogen is really not a thing. It's a class of things. It's a group of things. There are a number of different estrogens. There's no such thing as estrogen itself. So the estrogens that human beings make, there are three of them: diol, estriol, and estrone. And if you think about it, we say E1, E2, and E3 because it's estrone, NE, estradiol, and estriol. And those are the three estrogens that human beings make. And men and women have them in our bodies. And so when we replace estrogen, we want to replace them with one or more of those three. So which one do you use? Well, it turns out that estradiol, or E2, is the most potent one. And you can give a woman estradiol for replacement, and you don't have to give her the other two. And in fact, most people today are using just estradiol because the estrogen receptors are widely distributed, and the areas where we need to get benefit are readily responsive to estradiol. So estradiol helps to protect the bones, for example. It helps to protect the cardiovascular system. It certainly eliminates most of the symptoms that we associate with menopause, and it has an important effect in the genital area. Estriol or estriol is a much weaker estrogen. It's about 8-to-1 in terms of potency, estradiol to estriol, which is one reason why many doctors don't really give it, but others do. So you may run into people who are taking what they call BHRT, and that's a combination of the two. It'll be a combination in various proportions of estradiol and estriol. And other doctors will give just estradiol. And, it's interesting because it all boils down to a person's preference, because there really is no good evidence that one form is better for a woman than another. That is, whether you replace estradiol alone or replace her with a combination of the two, we don't really know which is better. They both seem to have a good effect, and they've never really been directly compared in any kind of prospective study. So, for example, in my case, I have some women on just estradiol and I have some women on the combination. And I find that either way, they'll do very well. Now, Estrone, the E1, is interesting because we don't even really know what it does, but it doesn't do what we want it to do. Giving her estrone isn't going to help a woman who's estrogen deficient, who's going through menopause. And most of the estrone is made in the adrenal glands, not in the ovaries. So if you look at a postmenopausal woman who is not on hormone therapy, you will be able to detect estrone in her blood, but not the other two.
When I interviewed Dr. DeRosa, she said, if anybody wants to give you Tri-Est, all 3 estrogens, she said, run. I would love to hear why, in your case, would you give some women Bi-Est or just one kind of estrogen?
To be honest with you, it's kind of random. The common, I agree, by the way, with Dr. Rosa. I don't know anybody, I've never seen a patient who was on Tri-Est. I've heard some doctors do it. I can't imagine why, because the estrone is not beneficial to her. And there's some evidence, although I don't know that this is verified, that high estrone levels may increase the risk of breast cancer. But there's just no reason to give her estrone. And some people believe that if you're giving too much of that hormone, it may block the effect of the others. They may compete for the estrogen receptors, and therefore you're taking away some of the benefit you might achieve from the other two that are useful. But to answer your question, it really is the physician's preference. I'll tell you how I do it. When I was originally trained to do it, I used Bi-Est. I used the 2 because it made sense to me that the 2 of them are active. And there are some parts of the body which have more what are called beta receptors. There are several receptors for estrogen in our body, and we have estrogen receptors everywhere. We have it in our brain, we have it in our genitals, we have it in our breasts, we have it in our organs, and we have it in our immune system. So it's important everywhere. So the theory is, well, why not give a combination of the 2, because both of those hormones are important for the youthful woman. And there are some parts of the body where it's actually preferred to give estriol rather than estradiol. For example, people who are taking facial creams. If you're taking estrogen cream on the face to help with wrinkles, which some patients, your clients may be doing, it's better to use estriol than estradiol because the estradiol is much more irritating. It's overstimulating. And also for women who experience vaginal dryness or pain with intercourse and difficulty with urination, because of the loss of estrogen effect in the vulvar area, you can use estriol alone because there's a lot of so-called beta receptors, which is the preferred receptor for the estriol, whereas the alpha receptor is the preferred receptor for the estradiol. But to answer your question more specifically, it's really just a question of the physician's preference in terms of whether you give just estradiol or the combination. I've heard some doctors say they believe that, and my initial thinking was that the reason for this is the alpha receptor effect on estradiol tends to be very stimulatory, and the beta receptor effect tends to be a little bit anti-stimulatory. So it seemed like you're balancing the woman by giving both. Whereas other doctors have argued against that, saying, well, then you might have the same problem with blocking receptors, and you really want to get the estradiol effect. So in the end, it doesn't really matter as long as she gets enough estradiol to relieve symptoms.
Let's dive into the damage from the Women's Health Initiative. What is it and what happened?
So the Women's Health Initiative was a study that was started in the 90s, and it was a huge study. It was tens of thousands of women were being investigated. And the idea was that, well, we have all these women that we're giving Premarin and Provera to. Is it really the right thing to do for them? Is it really safe for women in the long term to be on hormone? And so it was a reasonable question to ask, and a very, very large study was done. And it was around 100,000 women. And this study compared women who were on hormone replacement therapy to those who were not. And the difference, and what was being used was Premarin orally and Provera orally, unless she had a hysterectomy, in which case she was on Premarin alone. These women were followed. Originally, the plan was to follow them for, I think, 20 years, and the study was terminated early in 2002 because they began to see a signal that they interpreted as a higher incidence of breast cancer in the treated women. So that became a huge public issue. I mean, it was all over the news. All the doctors were told about it. It was on Time magazine. It was on, all the major networks. This huge study, this giant NIH-funded study is showing that taking hormones causes breast cancer. And breast cancer, of course, everybody's very fearful of it. I mean, it's an epidemic problem. Every woman has to address this in her own personal health because it's so common. And immediately, hormones were stopped in women who were experiencing menopause. And the problem was the data was improperly analyzed, and the group of women that were treated was the wrong group of women. There were a lot of women who were smokers in that group. They didn't account for the smoking issue. The women were older. Most of them were in their 60s, which is not when we start these therapies. And there were other factors that were really not accounted for. And then when they analyzed the data, they misinterpreted it because the signal was that there was some early breast cancer, and then later on there was less breast cancer. So you have to look at it over an extended period of time in the large group of women that were studied. And since then, quite a number of papers have been published in the medical literature which reanalyze the raw data. And this is what emerged, that they were mistaken. And in fact, the increased incidence of breast cancer was a very, very small, 1 in 1,000 women. And it was really misinterpreted. The problem was, the genie was out of the bottle, so to speak. Once everybody believed that estrogen was causing breast cancer, it's very hard to change that. And the original investigators have never really redacted their initial opinion. Their careers have been based on this. And it turns out that the difference in the frequency of breast cancer when women who were on hormone versus those who weren't was 1 extra case of breast cancer for every 1,000 women. 1 out of 1,000. And that's barely statistically relevant. Interestingly, the women who were treated with estrogen alone, that means they had had a hysterectomy. So many of the doctors were treating those women without progesterone. The women who were on estrogen alone actually had a lower incidence of breast cancer than the untreated women. And the women who were on estrogen with the progesterone had that 1 in 1,000 difference. What we don't know about that is that all those women were being treated with the synthetic versions. They weren't being treated with bioidentical hormone. All of that data is kind of a little bit irrelevant because it wasn't really appropriate. They were treating women who using the synthetics. They were using all oral versions of hormone, which we'll talk about that as well. And they were also giving it to women in their 60s. They weren't giving it to women at the time of menopause or perimenopause. And right now, all those things are a no-no. We don't do those things now. So a lot of the data that emerged from there only led to a terrible consequence of millions of women who were going through symptomatic menopause not being afforded the opportunity to get hormone. And to this day, many, many physicians and many people in the public still think that there's a breast cancer risk and that you shouldn't use these hormones. And this is unfortunate. I run into this every week. This is still commonly believed, and not just by people, it's by the doctors in many cases. But of course, in recent years, and thanks to certain leaders, people who have really championed women's health, people realize now that that was a terrible problem and that women were denied the opportunity. And now more and more people are waking up to women's health in general and to providing women with the care she needs. Because there are many benefits in giving a woman hormone replacement therapy, benefits beyond just the symptoms we talked about. Remember, you want to protect a woman against developing osteoporosis, and estrogen will prevent that.
Yes.
You want to protect a woman from getting cardiovascular disease, and estrogen reduces the risk of cardiovascular events. And it may even reduce the incidence of Alzheimer's disease, which is actually becoming an epidemic problem. And, women are more at risk for Alzheimer's than men. So we're going to find out as the years go on whether the women who have been treated with hormones may actually have a lower incidence of the dementia. Only 15% of menopausal women are getting hormone replacement therapy, and that's too low a number.
I couldn't agree more. That is too low of a number. Why do you think only 15% of women are seeking treatment in the form of bioidentical hormones?
I think it's largely because many people are still afraid of the risks of cancer. Many doctors are still believe that it causes breast cancer, and I think that's the main reason. Ashley, it's really amazing. Almost every week that I see a woman who comes to me who's interested in this, she tells me the story that she went to her gynecologist and she explained that she was experiencing several symptoms, any of which some of the ones we mentioned, and the gynecologists are, in many, many cases, are not offering them hormone. They still will offer them antidepressants. I just saw a woman yesterday who's been having trouble for about 5 years, and she's still in her 40s. I think she's 48. She started getting problems around 43. And the doctor wanted to put her on the birth control pill, which is synthetic estrogen and progesterone. She's 40, it's just birth control. And she was very upset because she's been to her gynecologist frequently with these symptoms, and she never offered the hormone. So I see this a lot, and I just think it takes more and more time. And these days, as a result of social media, as a result of podcasts like yours, people are taking charge of their health, and they're beginning to learn more and more, and they're not necessarily getting all their information from their physicians as we used to years ago. And so I think it's patients that will come in and say, look, I want to be on this treatment. I've looked into it. I know that this treatment is going to help me, and that I'm not worried about the risks.
I think a really good way to view what we're talking about is to flip the sexes. If a man went into the doctor's office and said he was having trouble sleeping, he couldn't really get it up, he didn't really feel interested in sex anymore or attracted to his partner, he's not going to be given antidepressants, most likely. He's going to be given testosterone. So can we talk about testosterone for women?
Sure. And I agree with what you said. I think that's a shame, but it's absolutely true. And this gets into a broader picture about, healthcare and how the medical profession has sort of viewed women's health issues. And women are different than men in a number of different ways. And a lot of times, unfortunately, women have been sort of gaslit in a number of different areas. One of them, of course, is what we're talking about, is going through menopausal changes, hormone changes. But another very common example in women is cardiac problems. A man comes in and says to the doctor, I'm having chest pain or shortness of breath. The doctor immediately tends to think of some kind of a heart problem and refers them. With women, they'll say, oh, you're anxious, you're just nervous, and in many cases, women don't experience cardiac symptoms the same way that men do. They can have a variety of what we would call atypical symptoms, and a lot of the doctors don't recognize this, and that's really unfortunate. Anyway, to answer your question about testosterone, yes, I am a big advocate of giving testosterone to women, and I always offer it to my patients, and I tell them a little bit about it, and I let them decide whether or not they choose to go on the testosterone. Now, most of the testosterone in a woman is made in the adrenal glands, but as a consequence of, so they don't have the same problem where the ovaries, become atrophic and are no longer producing hormone. They're still getting some testosterone. But, testosterone is very important for a woman. Most people don't realize that women have more testosterone in their body than estrogen by a significant amount. And men need estrogen in their bodies. It's just the ratios. Men have a lot more testosterone than women, and men have a lot less estrogen than women. But both sexes need both. And as a woman gets older, she begins to produce a little bit less testosterone. Typically, you don't see the testosterone go down to very, very low levels that would cause a clear deficiency. So it's not as much of a necessity as the estrogens and the progesterone is. However, supplementing testosterone in a woman has many different benefits. Those include energy, strength, support for her bones, confidence. I call it mojo. It gives a lot of women sort of self-confidence. It really has, both of these hormones have an important effect on the brain, and it really helps. Estrogens and testosterone help with your confidence, with your focus, with your your cognitive function and with your mood. They're really important. And then, of course, testosterone helps a lot with libido. And a lot of women who may be experiencing impaired sexual activities, usually impaired libido or impaired sex drive, testosterone can be very helpful in that regard. So I typically will offer it to my patients. When we talk about the different forms of administration, I'll get into it in more detail, but I'll often mix my testosterone in with the estrogen cream to make it a little easier for her. Then the question is, well, what are the downsides of giving testosterone to a woman? And it has a lot to do with proper dosing. You don't want to give too much. If you give her too much, for one thing, too much testosterone can cause a little bit of agitation because it gives you confidence and mojo, but if you give too much, it can give you a little bit of roid rage. We used to say it can also make you a little bit hypersexual if you're giving high doses. It can cause acne and hair growth, or hirsutism, hair growth in unwanted places. Some women, even at reasonable doses, will experience a little bit more hair growth. And one of the biggest concerns for women is the loss of hair. Like men, we get, pattern baldness, and some women can get pattern baldness too. And about 10 to 15% of women on testosterone supplementation will experience hair loss. So that's a big concern. But most of the time, it doesn't cause hair loss on the head. It'll just cause hair gain on the arms and legs, for example.
And maybe the face.
Sometimes, not too often. That I really don't like it when that happens. But you don't have to use a very high dose. You use a low dose, and it's enough to benefit her without causing those problems. And for those women who are active physically, who go to the gym a lot, who like to exercise and work out, they really enjoy the benefits because it really helps with their physical stamina and strength and their recovery from workouts.
When you are dosing testosterone, will you look at lab tests first? And if so, are you looking at free, total? What are you looking at, David?
I don't find that the laboratory is really that helpful. And the reason is in part because the way we have to give testosterone to women in most instances is in a cream form. Sometimes we'll give it in pellet form. Very rarely do we give it in injection form like men get it. And because men use much higher doses, we tend to use injections for men, and for women, we tend to use the cream. And one of the things about using creams and gels to provide hormone therapy is that the absorption is very variable. Some women, it depends on the nature of their skin, how thick their skin is, the characteristics of their skin. One woman might be able to take 3 milligrams a day and get an excellent effect from testosterone, and another may need 6 or 7 milligrams a day because she doesn't absorb it as readily. So it really has to be individualized. Now, it is true that if their blood hormone levels are very low, I'm inclined to start at a slightly higher dose. So I will look at their blood total and free testosterone, and that will give me somewhat of a guide. But in the end, it really has to do with her clinical response, how she feels. And that's very important. It's more important than using the laboratory.
Well, I like the sound of that. When you start using creams for a woman, does she need to use testosterone cream every day?
I usually recommend it, but some women will use it 3 times a week or something like that. Again, it depends in part on how we're administering the hormone. If I'm giving her estrogen cream that's compounded and has the testosterone in it, then I want her to take it every day. If she prefers to use the testosterone on and off, then she has to have a separate means to obtain the estrogen, either from a patch or a pellet. So for many of, I would say the majority of my patients, I mix it together to make it as convenient as possible for her, and then they're taking it every day. But it's not as essential. The estrogen and the progesterone should be taken every day.
So let's talk now about the modalities and how you deliver these hormones. You've mentioned creams, you've mentioned pellets, injections for men, not women. So walk me through our different options.
Okay, so basically all these hormones can be taken orally, topically in a cream, topically in a patch, by a injection, by a trochee. Trochees are like little lozenges that melt under the tongue, and by pellets. So there are lots of options. And when I first consult with a woman, I tell her about the options, and I say, look, I just want to get these hormones in you. These are the options. You're going to choose how you want me to do it for you based on what your personal preference is. So, for example, many women are using the estrogen patch. The estrogen Well, before I get to that, I always discourage a woman from using oral estrogen. In contrast to the progesterone, which is better given orally for the reasons we discussed earlier, estrogen can be given orally, but it should not. And the reason for that is when the estrogen goes through the liver, it has the effect of increasing the cholesterol and increasing the fibrinogen. Fibrinogen is a protein that's involved in the blood clotting mechanism. And for that reason, it increases the cardiovascular and blood clot risk. Some of your listeners may be aware that when a woman's on birth control pills, which is, of course, an oral form of synthetic estrogen, they're always advised don't smoke because it increases the risk of a blood clot and a pulmonary embolism. And that's the same mechanism that's going on. So when we use estrogen, I don't have a single patient in my practice that's on oral estrogen. But there are some people who will do it. Now, all of the other forms are completely safe. Now, and this leads a woman to make a choice. Does she want to use a cream or a gel? Does she want to use a patch, or does she want to use the pellet? So pellets. Pellets are not as common, but they're extremely beneficial for a couple of reasons. Pellets are small. They look like Tic Tacs, the candy Tic Tac, and they're small pellets that are composed of estrogen or testosterone, and they're compressed into this little pellet using usually stearic acid. And what they're inserted under the skin, usually in the hip region, into the sort of the fatty layer, and they gradually dissolve over a period of 3 to 4 months. And what happens is the capillaries just absorb it, and that gives a woman a very good sustained level of hormone. And that's probably the best way to get a sustained high level of hormone. And the convenience of that is that you don't have to take a cream or a pad. You're good to go. Once you establish the right dose for her, she's good to go. And my patients who are on pellets come to me every 3 to 4 months. We put the pellets in and they go about their business. It's a minor surgical procedure, so it's a little bit of discomfort, but it's really minimal. But more commonly, people are using either creams or patches. Patches have the advantage of typically they're estradiol, they're bioidentical estradiol, and the patch is put on and it stays on for 3.5 days. So we use 2 patches a week. And that's a very attractive option for a lot of women. The disadvantage of patches is that some women will be irritated by the adhesive. They might get an itch or a rash there. Some women have trouble where they fall off, and that can be a little annoying. But my biggest objection to the patches is the fact that A, they're fixed doses, so you don't have as much dosing flexibility. And B, you can't put Bi-Est in there. You can't put testosterone in there. So if she's going to be on a patch and I want to give her testosterone, I have to give her another cream on top of that. But a lot of women still prefer the patches, and they work very well. As far as the creams go, creams they make a gel, it's called Divigel, which also is fixed dosing, and you can get that from the standard pharmacy. But I typically will get my hormones from compounding pharmacies where I can make up a cream that has exactly the amount of estrogen that I want her to have, and I can put in there Bi-Est or just the estradiol, and I can put in all different ratios, and I can add the testosterone to it so that it's just a single cream that she puts on every day. The disadvantage of cream is, well, you have to put it on every day. But the advantage of cream is that you have more or less infinite dosing possibilities. Typically what I'll do is when I start a woman on a program, I'll order the cream and I'll say to her, okay, put this cream on every day, rotate sites, don't put it on in the same place, move it around every day, and put it on after you shower, then wash your hands. And I want to hear from you in 2 weeks, because by then you should feel the benefit. And I want to hear from you. How do you feel? Did it help you? Are you still getting hot flashes? Are you still feeling irritability or something like that? Are you still getting aches and pains? And then I'll know, okay, well, then I can say to her, okay, well, I want you to put a little bit more cream on, because they come in measured devices, so we know exactly how much she's going to put on. So that's my preference in those cases, because I can say to her, oh, put on 1 extra pump or 1 extra click. And then we can work together to find out what dose is ideal for her based on her body's needs and how well she absorbs it. And then I can reformulate the cream so that she's just on a standard dose that's a fairly small volume. Because if I have to keep increasing the amount, then you don't want to put on a large amount of cream. It gets a little messy. So I like to concentrate it down to make it as simple as possible for her.
someone on my podcast who said, when you're using estrogen in a topical form, you have to wash your hands and make sure that if you put it on your butt or under your thighs and then you use the toilet, that you then wipe the toilet down because it can transfer to other people in your household. Would you agree with that and tell people to be a bit cautious what they touch after they use estrogen cream?
Yes, I think that you can transfer it, especially, some women say, well, can't I just put on at night before I go to bed? And that's fine. But if you're going to be cuddling with your partner, you can transfer directly, because even though you're going to spread it out along the skin, let's say on your thigh, right? Even though you're going to do that, it still takes about 30 minutes to completely absorb in. So that's why I usually tell people, you know what? Don't put it on the back of your thigh. Put it on the side of your thigh or the inside of your thigh. And if you have to use the toilet, you're not going to transfer it. And then you'll just get dressed over it and you'll be okay. But there have been cases where people have transferred some of the hormone to their partner or even to children. If you're carrying a baby or a grandchild or something like that, it's another reason why you want to be clothed over it. You don't want to be wearing a bathing suit and then playing around with the child unless you've waited at least 30 minutes. So it's definitely something to be aware of.
I haven't heard the example of putting cream on different body parts. Can you walk me through that way of thinking?
For most people, it's best to put the cream in an area where you have some subcutaneous fat. And the reason for that is all of these sex hormones are derived from cholesterol. Many people don't realize that. Our body makes it. The original product is cholesterol. And that structure chemically gets converted to all of the sex hormones, progesterone, estrogen, and testosterone. As you know, cholesterol is a fat. It's an oil-based product. So it tends to be more soluble in fatty areas, in oil-based areas. So if you put it on the skin, it goes under the skin, it goes through the fatty layer, it tends to be absorbed better in most cases. Now, there are some people, so for that reason, I typically like to use the thighs. I'll say, because everybody has some fat on their thighs, or you can use the butt too, wherever you have a little bit of fat. And so that is where I usually recommend people start. Now, I also tell them to rotate sites every day and not always put it in the same place. There are two main reasons for that. One reason is that if there's testosterone in the mix and you keep putting the testosterone there, you can actually grow a little patch of hair there. And nobody wants that. If you move it around every day, that's not inclined to happen. The other reason is that there's a concept of what they call dose dumping. Interestingly, the mechanism of which is not well understood, but if you always put it in the same area, over time, the absorption diminishes. So you'll need a higher dose to get the same amount of absorption. But if you move around every day, that doesn't happen. So I always like the people to rotate. It's interesting that some women who I guess have thicker skin don't absorb as well by that mechanism, or they have trouble and they keep needing higher and higher doses. Sometimes when that happens, I'll tell them, well, maybe you're somebody who needs to absorb in an area where the skin is thinner. So in that case, I'll tell them to do it like here on their wrist, where you have thinner skin and there's no fat there, or right behind the knee. And the back of the knee is similar. And occasionally I'll see patients who seem to respond better when we do it that way. But that's sort of my plan B.
So interesting. I haven't heard this before. When I was prescribed testosterone, I was told to put it on thin skin. But what you said about cholesterol and under the subcutaneous fat, that makes so much more sense. And I would always put it on my wrist, but now I feel like I'm going to put it on my butt and thighs instead.
Yeah, you can see how you do and see whether you get a little bit better absorption that way.
Is there an area where we shouldn't be using these creams? For instance, our breasts?
It's interesting. It's probably a good idea not to put it on your breasts. I mean, despite all the things that we said before, all these studies are based on people who are taking it in other areas. So the idea is if you put it on your breast, you'd be getting a lot of hormone in that area before it distributes throughout the body. So it sort of sounds intuitive that you don't want to take any chances. And besides, one of the symptoms or side effects, I guess I should say, of starting it is some women will experience breast tenderness because there's a lot of estrogen receptors in the breast. So if you put it on your breast, you're more inclined to get sore breasts. Who wants that?
Okay. David, I've been waiting to ask you this question
Okay.
If we start taking bioidentical hormone replacement therapy, do we need to take it for the rest of our lives?
The short answer is yes, as long as you want to stay youthful and you want to protect your bones, heart, and brain, and your skin, and your vulvar area, there's no reason why you shouldn't continue it indefinitely. Now, there are some, let me just say that there are some physicians who believe that you should only do it for a limited period of time, typically 3 to 5 years. And their justification for that is that most of the symptoms will be gone in 3 to 5 years. As you probably know, if a woman goes through menopause and doesn't take hormones, she may go through a period where she's having a lot of hot flashes and some of those types of symptoms, but they tend to go away. The vasomotor symptoms in particular, we call those vasomotor symptoms, they tend to go away over time anyway. So some doctors say, well, you're not going to have these symptoms anymore. So, you only need it for 5 years, and that way you're not taking any risk. I completely disagree with this. First of all, once you stop taking it, you're going to go through menopause. So your bones are going to start, resorbing calcium, and your bones are going to weaken. You've lost the cardiovascular benefit. You've lost the benefit on your skin and hair and nails. You've lost the benefit on your vaginal tissue and genitourinary tissue. So you'll begin to get vaginal atrophy that can cause, burning with urination, frequent urinary tract infections, painful intercourse, vaginal dryness, and discomfort. So why would you want to stop?
I like that answer.
There are some doctors who will say, okay, well, I recognize that there could be a problem in the genitourinary area, so they'll just give some vaginal estrogen. And it's true that if you just give vaginal estrogen, which can be done in forms of either creams or like suppositories that are inserted into the vagina, those are very effective, and they don't give you systemic estrogen. They just stay locally in that area. So they really can help that particular problem. They just don't help all the other problems. And, occasionally I'll have a patient who, despite being on a systemic treatment, still needs a little extra vaginal estrogen. So that's perfectly fine if you need to give a little bit more in that area. And I did forget to mention one thing, which when we were talking about means of administration, you can also provide this vaginally instead of doing it on the regular skin. When we do that, I don't do that very often, but there are some instances in which I will do that. The doses are lower because the mucous membrane is very thin and it's very readily absorbed. So you're using a lower dose. But one of the reasons for doing that is if there's a real problem with impaired sexuality and impaired arousal, that when you put testosterone and DHEA into the cream and you put it into the introitus and the vaginal area and the clitoral area, it really enhances the sexual experience. So there are some women who really have some sexual dysfunction, and this can be part of a plan to address that.
We talked a lot about symptoms, and I know I had referenced labs once, but will you run labs when a woman comes to see you?
Ashley, you ask all of the great questions. You know that? That's wonderful. Because that way we're covering all the important issues. So I thank you for that. So it's really important to discuss this a little bit because it's confusing. So traditionally, no one used labs to monitor hormone replacement therapy. When a woman presents with symptoms, it's pretty clear. You don't need the lab to show you that she's menopausal. We typically do it, and you'll see very low progesterone and estrogen levels, and you'll see elevations in the pituitary hormones, FSH and LH. FSH and LH are the pituitary hormones that stimulate the ovaries to make hormone and to make eggs in the younger woman. And what happens is once the ovaries fail and they basically atrophy or turn into raisins, I say, they're no longer functioning, the pituitary hormones, FSH and LH, will go up. They'll rise because the body's asking for more estrogen. So typically in the menopausal woman, you'll see a high FSH and LH, and you'll see low estrogen and progesterone. Sometimes it's useful to get the laboratory. Let's say a woman had a hysterectomy and she doesn't have her period. She can't tell you whether she's having her period anymore. She just may be having symptoms, and you're not even sure whether this is all, that she's going through perimenopause. That's where the laboratory can be very helpful in distinguishing between that and other causes of those symptoms. But most of the time, clinically, it's pretty easy to tell what a woman's going through. What about monitoring therapy? Once you put her on whatever form of treatment, we discussed lots of different kinds. Whatever she goes on, how are you going to monitor her treatment? Again, traditionally, it was just done clinically. In other words, there was no measurement. You just said, how do you feel? Are your hot flashes gone? Are you sleeping? Do you feel good? How's your libido? And if she said, I'm feeling great, which most women will say that, you leave it at that. Okay, no reason to make any change. That's still the way many people do it. I don't. I like to monitor, and I'll explain why. It's really difficult to measure it accurately because when you're taking hormones, and it depends in the manner in which the woman is taking hormones. So, for example, if you're taking your hormones by a cream or a patch, therefore you're getting it through the skin, what happens is the hormone gets distributed through the body fluids first and secondarily in the blood. So you tend to see much lower blood levels than you would if a person's taking it by injection or by pellet. Because when you're taking it by injection or by a pellet, the estrogen goes absorbed through the capillaries, through the blood stream, and then gets distributed. So it can be difficult to interpret levels based upon blood tests in women who are on patches and creams. And this is poorly understood by a lot of doctors, and this is particularly the case with men on testosterone, because some men who take testosterone are taking testosterone creams, and you measure it in the blood and it's still low, and they keep giving it more and more and more and more and more, which is not the right thing to do. So you have to combine blood testing with another means of test. And there are two other ways of approaching it: salivary testing and urine testing. The saliva represents something similar to what the body fluids are. So if you measure the amount of estrogen and progesterone and testosterone in your saliva, you're getting a pretty accurate amount of how all your body fluids have those hormones. So that's one good way to do it. And that just means that your patient has to just kind of provide a spit into a little test tube and provide a salivary sample. Another way to do it is to test it in the urine. When you test it in the urine, you can test not only the estrogen, progesterone, and testosterone, but you can also test the metabolites. And what that allows you to do is you can add it all up together, and if you know how much is coming out of her, you know how much she has in her system. And the advantage of doing it in the urine is that in addition to getting a good measure of how much is in the body, you can also see how she's metabolizing the estrogen, because there are several different pathways of metabolism, which also reflects the way we detoxify a lot of environmental pollutants, things like BPA and other pollutants that are estrogenic-like compounds. They're metabolized by the liver using the same pathways that we use to metabolize the hormones. So I like to measure those because there are three main pathways, and I can see whether the woman is using preferentially, if she's using a pathway that's easier to get it out of the system, or whether it tends to recycle and accumulate certain metabolites, which might be disadvantageous for her health, and how well you eliminate things from the body. So I really like to do the urine test for that reason, because the means by which a woman metabolizes is in part genetic and it's in part environmental, but you can take certain. In particular, we use the supplements that come from cruciferous vegetables. And cruciferous vegetables have something called sulforaphanes in them, and they have something called DIM, or diindolylmethane, in there. And what that does is that blocks the bad pathway, so to speak, and enhances the pathway that eliminates it out of the body more readily, because it's coming out in our urine and in our stool. And this helps to eliminate it more readily. So you're not only getting rid of the metabolites you don't need, but you're also getting rid of any kind of environmental toxins. So I really like to use that. Some doctors will give women those supplements as a pill supplement, regardless of the testing. They just say, well, I think it's a good idea to take the DIM or take the sulforaphane or a cruciferous vegetable extract. The only reason why I don't do that is I don't, if it's not necessary for her, if she's optimally metabolizing anyway, why bother? So I don't routinely give it to them unless I see evidence for it.
Can you walk me through what is the loop phenomenon?
I don't know that. I don't know what the loop phenomenon is. You tell me.
My understanding is that in perimenopause, it's where you don't release an egg. Therefore, it drives your estrogen up. And then you can experience more symptoms because your body's trying so hard to release that egg, but it's not happening for you in that certain cycle.
You know what? I've learned something from you. I'm not familiar with that problem. I haven't seen that happen. And so I can't really comment on it, Ashley. I'll have to look into that.
Okay. Well, that was going to be one of my other questions, because we started off this conversation with your wife having symptoms. And so then you took a deep dive into learning about hormones. I would love to hear, what kind of books did you read? Courses did you go to? How did you learn so much about hormones?
I originally I started going to certain conferences, and I was interested in, and there are a number of different organizations that really focus on these issues. And the first conference I went to, this is about 16, 17 years ago, was a conference by an organization called AMMG, which is called Age Management Medical Group. And I went to this conference, and they were talking about many different issues in anti-aging. And one of the segments in it was by a gynecologist from Johns Hopkins who talked about everything we're talking about hormone replacement therapy in women. And she gave an excellent talk, and I went, and I was trying to learn about this at the time, and afterwards I approached her, and she had written a book, she gave me her book, so I read her book, and that's how I got started. And she said to me, I said, how can I really learn more about this and how to be expert in this? And she said, you should go to A4M, the American Academy of Anti-Aging Medicine and Regenerative Medicine. So I then went to A4M, and that organization really did a tremendous amount of training. They have a huge, what they call module, just on hormone replacement therapy, series of lectures and really a lot of detail on hormone physiology and female physiology and using the hormones, many of the things that we're talking about. And so I spent a lot of time learning that with A4M. And then there were certain sort of expert, advanced seminars that were being offered. But if people want to learn more about it, one of the books that I really recommend that's very accessible for anybody to learn more about this is called Estrogen Matters by Blooming. Are you familiar with this book? That is an absolutely excellent book, because not only does it discuss many of the topics we did, specifically addressing the safety of estrogens. They even go so far as to talk about women who've experienced breast cancer and who have been treated successfully for breast cancer, and asking the question whether they are suitable candidates for hormone replacement therapy if they feel the need. In fact, when the answer is you can, as long as her breast cancer has been successfully treated and she doesn't have active disease. But he also discusses in great detail some of the problems with the Women's Health Initiative, why it was misinterpreted, and explains in very easy to understand terms why hormone replacement therapy is helpful for women and how to do it safely.
I know this whole Yes, I am. I actually read it when it first came out. I was listening to a podcast and I didn't know anything about hormones at the time, but I thought it sounded really interesting. So I read it when it very first came out.
Yes, there was also and there are a number of books. There's a book, Pamela Smith. Are you familiar with Pam Smith?
No.
Pam Smith is I would call her sort of a pioneer and a leader. And she just has a book that says what you should know about female hormones. And Pamela Smith is very, very good. I learned a lot from her. She's very active with AM and as an educational physician teaching all about hormone replacement therapy. It's a very good resource. That one tends to be a little bit more, I guess, for physicians, but it's a very good book. And then another one of my I would say mentors is Jennifer Landa. Do you know Jennifer Landa? Jennifer Landa is the medical director of Body Logic MD, and she wrote a book on female sexuality and how female sexuality changes as we get older, and the importance of hormone replacement therapy. And it's a very accessible book. Jen Landa, I do recommend that.
Great. I'm going to put these in the show notes for everyone to find them, because I feel like the more resources we can get our hands on, the better. Because my personal story is when I was 37, I felt like I was going crazy. I was walking to the gym one day, listening to Eminem like I should be hyped up. And I was so sad and crying. And everything my husband did pissed me off. The way he was breathing, the way he would do the dishes, like everything. And I was so upset and frustrated and feeling emotions that I had never felt before. So that's when I started listening to as many podcasts as I could until I finally heard the word perimenopause.
Yeah, not alone. There are other women who go through this in their late 30s, but those women are often missed. It's not recognized. They'll go to the doctor and they won't even think that it might be related to they're getting early perimenopause, and they'll end up on Valium or Xanax and Prozac and those types of things, because it's usually felt to be a purely psychological matter. And, it's really important that you spread the word, because I'm sure there are women who may be listening who are, really only 39, 40 years old, and they're having difficulties. And it may not be recognized.
That's right. That's part of the reason for this show. Now, David, I'm really curious to ask you because we've both mentioned how a lot of physicians don't know what they're doing when it comes to hormones. So let's say someone has decided to take the initiative and see their doctor to ask for hormones. What are some top questions they should be asking?
It's interesting. I'll just tell you a little bit of a story in answering this question. When I first started doing this years ago, typically I would say to the woman I was seeing, I'd say, look, this is what we're going to do. And I want you to go tell your gynecologist and your primary care physician that we're doing this because your doctor should know what you're doing. And, you should just tell them that this is what we're doing. And I said, you may get a little pushback from them, but we can talk about it. And I will tell you that in the beginning, probably close to 50% of the time, the doctors would freak out and say, who is this guy? Why are you doing this? You're going to get cancer. Don't do this. And this happened a lot over the first several years. And it was interesting. A lot of women, I would tell them, they didn't want to tell their doctors because they'd already been to them and they didn't want to give them hormones. And I said, okay, that's your choice. But many of them would say to me, I don't really care what those doctors say because I think you're right and I can't live like this anymore. And I want to get better. So they would do it anyway. Anyway, as the years went on, there started to be slowly, gradually more acceptance. And so then instead of the doctors telling the woman to stop the treatment, they would say, oh, okay, well, as long as some other person is doing it, then as long as he's doing it and you're going to him, that's okay. I'm not going to deal with it, but it's okay with me that you're doing it. So that was a movement in the right direction. In the last couple of years, I've noticed that a lot of the doctors, well, not a lot, but more of the doctors are saying, oh, I can do that for you. You don't have to go to him. So more and more people are doing it now, which is great. I mean, you want access for the women. So, if a doctor recognizes that a woman can benefit from this and he or she feels comfortable doing it themselves, that's great. If they feel like they want to encourage it, but they're not familiar with how to do it, that's fine. They can refer. But I do think that you want to make sure that the doctor has experience doing this and that he or she is able to offer you the several different mechanisms of administration, right? You should have an option. Do you want to go on a patch? Do you want to use pellets? Do you want to try creams? Are they familiar with, should testosterone be added? What do they say about progesterone? All of the topics that we touched on, you can ask the doctor about. As long as they're familiar with these things, then you can feel confident that she knows what she's doing. But I have to say, I'm sorry to say, I've seen patients who've come to me in consultation, but they're starting treatment with other doctors, and a lot of people are doing it what I would consider to be wrong dosing, wrong schedule. And, some people just started to just do it on their own, and they didn't really take a deep dive to really understand it. Hormone therapy is much more complicated because each person is so different, unique in the way she responds. You really have to individualize it. And I used to run into certain kinds of problems and I didn't know exactly how to deal with it. You really need experience. So that's why I was doing a lot of these conferencing, and some of the people I mentioned who were kind of mentors to me, I would ask them, I would call them up and I would say, look, I have a woman who's having this problem. What should I do? What do you do in this situation? And that really helped me a lot gain confidence and the ability to really serve my patient in the way that she needs. Now, so if you're going to go to a physician and get this type of treatment, you want to know what kind of experience they've had doing this and, how long they've been treating patients in this way and whether they, how they feel about the use of progesterone, whether it should be oral or creams, how they feel about compounding bioidentical hormones, how they feel about testosterone. And based on the way they answer the question, you can make a decision whether they're the right doctor for you. Because I still see doctors sometimes giving women oral Premarin, which works, but it's not really the right way to go in 2025.
Well, I appreciate you sharing the light and sharing this information for more people to find it. David, as we wrap up this podcast, I ask all my guests the same closing question, which is, what haven't I asked you that you'd like my listeners to know?
That's a good question. I think you did a great job. You asked me a lot of important issues. What haven't you asked? We talked about the different means of administration. We talked about monitoring. We talked about risks. I hope we covered all those bases. I think you did a really thorough job, Ashley. I don't think there's anything else I need to add. One last thing that maybe we can talk about is there needs to be a healthy ratio between progesterone and estrogen. And if there gets to be too high estrogen in relation to the progesterone, you can begin to experience a little spotting. That tends to be very frightening for women. This is a physiologic thing. It doesn't mean that there's endometrial cancer or anything like that. And what I will do then is I will ask her to reduce the estrogen for a few days, increase the progesterone for a few days, and it should go away. If you're a menopausal woman, you really don't want to see spotting. And this will occur occasionally, typically if the estrogen dose is too high in relation to the progesterone. Only if it becomes a persistent problem do they need to go to the gynecologist. And the reason why I'm saying this is because if they do go to the gynecologist, invariably what they're going to do is an endometrial biopsy. Because the conventional treatment for a woman who is menopausal and has vaginal bleeding is to do an endometrial biopsy to rule out endometrial cancer or endometrial hyperplasia. And the problem is that if a woman's on hormones, this is a physiologic response to dosing variations. So that's not a pleasant experience for a woman to go through. And I don't think that she should go through that experience unless it's really necessary. So that's another example of where you need to be working with somebody who's pretty experienced, because when you run into these problems on occasion, you want to be able to manage them in the safest and most effective way.
Great parting advice. David, where can people go to find out more about you?
The easiest way is on my website, which is pretty easy. It's just drlands.org. And there it tells a little bit about my practice and the types of things we do in our practice, and gives our contact information and our location in New Rochelle, New York. And
do you take telehealth appointments if people want to visit you from all over the nation?
I always like to see people in person, but sometimes that's not possible. So we do telehealth, absolutely.
Okay. Great. Well, David, thank you so much for your time today. It's been a pleasure speaking with you.
Thank you so much, Ashley. I really enjoyed it.
This podcast is a labor of love, and I'm dedicated to providing free content for years to come. If an episode has brought you joy, clarity, or valuable insights, your support means so much to me. A quick shout out on Instagram or sharing this podcast with a friend can make a big difference. If you're not listening on Spotify or Apple Podcasts, a great way to help support the show, or even on YouTube, is by leaving a review. You can also help support my work by using any of the affiliate links that I leave in my detailed show notes, or visit my website, ashleydaily.com. I'm most active on Instagram if you're looking for me, so you can find me at Ashley_Daily. Sending you light, love, and gratitude. This podcast is presented for educational and exploratory purposes only. Published content is not intended to be used for diagnosing or treating any illnesses, disease, or disorders. Those responsible for this show disclaim any responsibility for any possible adverse effects from the use of this information presented by myself or my guests. Please consult with your healthcare provider before using any products or services referenced in this podcast. This podcast may contain paid endorsements for products or services, and any third-party materials or content of any third-party site referenced on this show do not necessarily reflect the opinions or standards of the policies of my guests. The podcast and my website, ashleydaily.com, present the opinions of myself. The content discussed on the show should not and does not replace medical advice, and the content here is for informational purposes only. Episodes on Welcome to Wellness may at times cover sensitive topics, including, but not limited to, depression, suicide, COVID-19, vaccines, events related to the pandemic, big pharma, nootropics, circumcision, psychedelics, hormones, the Women's Health Initiative, birth control, the use of plants medicine, abortion, geoengineering, terrorism, gender, AI, and sex, drugs, and rock and roll. You are advised to refrain from listening to this podcast if you are likely to be offended or adversely impacted by any of these topics. However, if these topics interest you, you just may have found your tribe. The information or opinions expressed on the Welcome to Wellness show are solely the views of the individuals involved and by no means represent absolute facts. Opinions expressed by the host and the guests can change at any time. The views of my guests are solely their views, and the Welcome to Wellness show does not accept responsibility for them. Any action you take on the information contained within the show is strictly at your own risk. The Welcome to Wellness host, Ashley Daily, will not be liable for any losses or damages in the connection with the use of this podcast. You should take all necessary steps to ascertain the information you received from this podcast is correct and has been verified. None of the guests or contributors on the Welcome to Wellness podcast will be responsible for your use of the information contained therewithin. Under no circumstances will the Welcome to Wellness show or my affiliate partners, suppliers, licenses, or guests appearing on the show be liable for any direct or indirect direct, consequential damages arising from the use of or inability to access this podcast. All intellectual property rights belong to Ashley Deely, including but not limited to the copyright and any other rights in the design. You are permitted to use the Welcome to Wellness podcast for personal use, but not for commercial use without license. Guests on the Welcome to Wellness podcast may at times provide information on or read extracts from third parties' copyrighted work. The Welcome to Wellness podcast does not provide any medical or professional advice within these episodes. Anything said should not be taken as replacement for medical, clinical, professional advice, diagnosis, or medical intervention. If you take any action or inaction as a result from the content you consume from the Welcome to Wellness podcast, this is based solely on your decision, and the Welcome to Wellness podcast and Ashley Deely and my guests cannot be held liable for any of the consequences of such action or inaction. Thank you.